And for this case discussion, I would like to invite the external examiner, Dr. Bikash Ranjan Ray. Sir is additional professor at the Department of Anesthesiology, Pain Medicine and Critical Care at All India Institute of Medical Sciences, New Delhi. Sir's area of special interest are critical care, regional anesthesia, ultrasound in critical care and anesthesia, and outcome-based clinical approach. Sir has several publications to his credit. We welcome you, sir, to APPEC2023. As the moderator for this session, I would like to invite Dr. P. Priya. Ma'am is Associate Professor at APPEC2023 and Dr. RML Hospital. And her area of keen interest are ultrasound-guided regional anesthesia and palliative care. Welcome, ma'am. The case will be presented by our postgraduate student, Dr. Akash Jadon from APPEC2023 and RML Hospital. He is a final year postgraduate student. Over to you, sir, for the proceedings of this session.
Good morning, everyone, and thank you for your kind introduction. So, am I audible?
Yes, sir, you're audible.
So, good morning, Dr. Supriya and Dr. Akash. Should we start the presentation?
Yes. Good morning. I will be presenting the case of patient with hypertension for modified radical mastectomy. My patient, Mrs. Vimla, she is a 48-year-old female and homemaker she is a homemaker and resident of West Patel Nagar, New Delhi. And she is educated up to 12th standard and she belongs to upper middle class socioeconomic status. She presented with the complaint of lump in her right breast since 6 months. She was apparently normal 6 months back, then felt a mass in the right upper part of the breast and progressively increasing in size. Initially, it was around the size of peanut and suddenly start to increase in the size of present to the present size. And the swelling is not associated with pain or discharge, and there is no history of fever, trauma to the breast, and no history of nipple retraction and nipple discharge, no history of loss of weight and loss of appetite. There is no history of similar complaint in the other breast, and no history of swelling in the axillary region, and no history of backache, shortness of breath, blood in sputum, pain, yellowish, discoloration of skin sclera, and headache or seizure. There is no history of radiotherapy or chemotherapy in the past, and the patient, when the patient went to general surgery department with these complaints 1 month back, and she was diagnosed with carcinoma breast after the workup, and was advised for surgical excision of the same. My patient is a known case of hypertension since 4 years, and the patient has a history of a mild to moderate headache and a family history of hypertension. When she went to clinic, she was diagnosed as hypertensive on evaluation and started on medication for the same. The symptom relieved over a period of time, and she was compliant to the treatment and on regular follow-up with the physician. This was not associated with any kind of chest pain, gabrat, palpitation, and difficulty in breathing. There is no history of weakness, paralysis of extremity, and a sudden episode of loss of consciousness and vision abnormality, decreased urine output, peripheral edema or puffiness in the face. There is no history of a severe headache, bleeding from nose, undue anxiety and redness, dizziness. There is no history of any psychiatric illness. There is no history of weight gain or loss, and no history of steroid intake or any other drug abuse and antipsychotic. She has no history of snoring and no history of any allergy or a seizure disorder in past, and she is fully vaccinated for COVID, and she has no history of any infection in the past. And there is no history of previous hospital admission or any other chronic medical illness like diabetes, asthma, tuberculosis, thyroid disease, and no history of allergy or surgical intervention in the past. Family history: she is married for 28 years with 2 children, and her father have a history of hypertension. And there is no history of breast cancer in the family members, no history of chronic medical illness like diabetes, asthma, and tuberculosis or thyroid disorder in the family. Personal history, she follows mixed diet, and she has a normal sleep and wake cycle and a normal blood bowel habit. She is a non-alcoholic and non-smoker. And she is married for 28 years, non-consanguineous marriage, and I have 2 children. Both are full-term and vaginal delivery and breastfed adequately, and menarche at 12 years and attained menopause at 45 years. No history of OCP and any hormone replacement therapy. There is a in treatment history. She's on hypertension medications in 4 years, and she's on tablet Telma H 40 by 12.5 mg or OD dose, and she's compliant to treatment, and drug and doses were confirmed by seeing the prescription. On examination, patient
one second,
yes.
Dr. Akash. So
Yes.
till now, can you summarize the case?
My patient is a 48-year-old female. She is a known hypertensive, and she presented to the she presented with the complaint of a breast lump in right breast, which was since 6 months.
And now posted for?
Sir?
Yes. So
Yes,
this
sir.
patient is a hypertensive with a breast lump posted for a breast surgery.
Yes.
That is the case. Huh?
Yes.
So, so in between, there are few history you have taken regarding history of intake of OC pills and other. How does that affect?
Sir, because of that, sir, there is an increased exposure to the estrogen. That is a causative factor for breast cancer.
Okay. Anything with cardiovascular disease?
Sir?
OC pills and cardiovascular disease are associated? Anything?
Sir, there is an increased phenomena of thromboembolism because of use of estrogen, and also, sir, it increases the chances of hypertension, causes hypertension in patients.
Also, there is some history you have taken that no history of any chemotherapy or radiotherapy for this patient has not received any chemotherapy and radiotherapy. So what are the anesthetic concern of the patient if he received some chemotherapy or radiotherapy?
Sir, patient receiving chemotherapy, sir, there are chemotherapeutic agents like cyclophosphamide and doxorubicin, usually used in adjuvant neoadjuvant therapy for the before breast cancer surgery to reduce the size of the lump. And sir, it is associated with the cardiotoxicity, and that causes the cardiomyopathy, and also causes QT prolongation that will affect the course of surgery and intraoperative.
And what about radiotherapy? What are the concerns with radiotherapy? So, okay, we'll discuss in the end what the concern with radiotherapy. You can continue your case.
Yes, sir. On general physical examination, the patient was examined after the informed consent in presence of a female attendant. The patient was conscious, oriented to time, place, and person, sitting comfortably on bed. Her height was 165 centimeter and weight 60 kg, and BMI was 22 kilometer per meter square. And she was afebrile on touch, no pallor, ictus, cyanosis, clubbing, or lymphadenopathy seen. The JP was normal, and the venous axis was easy. The pulse rate was 80 beats per minute in right radial artery, which was regular in rhythm and good in volume, normal character, no radio-radial or no radio-femoral delay, and all peripheral pulses was felt. And BP was 128 by 84 mm of Hg, measured in right upper arm in supine position. And Respiratory rate was 15 per minute, normal thoraco-abdominal type, and SpO2 was 99% on room air. In airway examination, the feces were normal, nose, bilateral ears were equal, and no deviated nasal septum or growth. And the mouth opening was more than 3 fingers. Interincisal gap is 5 centimeter. With good oral hygiene, no loose artificial buck teeth, and modified Mallampatti class was 1. And the neck, sternomental, thyromental, hymental distance were within normal limit, and the full range of motion, movement of the neck. On local examination, inspection done in sitting position, the level of nipple, right nipple appear little lower when compared to the left, and on examination of right breast, a mass is seen in upper outer quadrant of the right breast, and the skin over the swelling looks normal. No prominent vein, redness, edema, and no dimpling or puckering, no nipple traction or discharge seen. The left breast looked normal, and bilateral axilla looked normal. On palpation, right breast, there is no rise in temperature and ill-defined lump of size 6 to 5 centimeter in upper outer quadrant, and the lump was hard, irregular in margin, non-tender, mobile, not fixed to skin, and free from nipple areolar complex and pectoralis muscle and chest wall. And the nipple areolar complex was normal, left breast was normal, and bilateral axilla was normal. On systemic examination, cardiovascular system inspection, the shape of chest was normal, no visible precordial bulge seen, and no scarred sinus dilated veins were seen, no visible pulsation or raise in jugular venous pressure. Apical impulse was seen in 5th intercostal space and 1 centimeter medial to mid-clavicular line. No abnormality in spine or rib cage noted. On palpation, inspectory findings were confirmed, and apex speed confirmed to be in the 5th intercostal space, 1 centimeter medial to clavicular line. No heave or thrill were palpable. On percussion, the right border of the heart correspond to the right sternal border, and the left border of heart correspond to apex peak. On auscultation, S1, S2 was heard, and no murmur and adventitious or added heart sound was audible. On the examination of respiratory system, on inspection, trachea seems to be in midline, and the respiratory rate was 15 per minute, thoraco-abdominal type, and bilateral chest movement equal and symmetrical, no visible scar, sinus, swelling, ulcer over chest wall and back or other, and no usage of accessory muscles of respiration. And on palpation, temperature was normal, no tenderness, bilateral equal movement of chest, and the chest expansion on full inspiration is 4 centimeter and diameter AP is 30 centimeter and transfer is 43 centimeter. And the vocal fremitus normal on both sides. On percussion, resonant in all area in sitting position, and auscultation, bilateral vesicular breath sound in all area, no added sound, or vocal resonance was normal. On examination of abdomen, inspection, the abdominal scaphoid in shape, all quadrant moving equal on respiration, umbilical central in position, normal in shape, no visible scar and sinus or pulsation, no visible lump, and annual sides was free. Palpation, inspectory finding was confirmed, and all 9 quadrant palpated, no superficial tenderness, no organomegaly, and on percussion, tympanic note on percussion, no shifting dullness or no bladder dullness, and auscultation, bowel sounds were present. On CNS examination, the patient was conscious, oriented, and cooperative, and with high mental function normal, and no neck rigidity. The cranial nerve examination was normal, and motor system, the nutrition was adequate, tone was normal, and the grade 5 power in all four limbs, and there is no involuntary movement seen. And sensory function, superficial sensation to pain, touch, and temperature was normal, and deep vibration, joint senses, and position senses were present. And reflex, superficial reflex was normal, deep reflex and visceral reflex were all normal, and cerebral test was normal. My patient is 50-year-old female, known hypertensive on regular treatment since 4 years, and presented with a lump in right breast.
Okay. So Dr. Akash, this patient is posted for a modified radical mastectomy. So what are the certain anesthetic concern in this patient for you?
Sir, for the patient, sir, she's a known hypertensive and she's on regular medication. And sir, for such patients, sir, because she's on a ACE inhibitor and sir, hydrochlorothiazide. So because hydrochlorothiazide is a diuretic antihypertensive, there can be sir concerns like
Okay, we'll discuss those things, but the main concerns are patient is non-hypertensive, controlled, and another concern is an antihypertensive drugs. Okay, concerns related to the drugs. So how do you define hypertension?
So hypertension is defined as the increased systolic blood pressure more than 140 mm of Hg, and or diastolic blood pressure more than more than 90 mm of Hg on taken on different time points or and reason.
Okay, so is there any subtypes of hypertension after the current guidelines?
Sir, hypertension can be sir primary or secondary. The primary hypertension is also called sir essential hypertension. That is most prevalent and seen in 90% of the hypertensive patients. And in the secondary hypertension, sir, it is associated with pathology, with cardiovascular or neuronal or hormonal pathologies.
So can you say the what is the probable or probable?
Sir? You are not audible, sir.
Am I audible now?
Yes, sir.
Dr. Akash?
Yes, sir. Yes.
So
Sir, I can't hear you right now, sir.
So I can hear you, but I don't know whether Dr. Supriya, am I audible?
Yes, sir. Now you are audible, sir.
Okay. Yes, Dr. Akash.
Yes.
So what is the pathophysiology for primary hypertension?
In primary hypertension, sir, because of sir, there is a sir, deranged sir, because there is an increased tone of vascular tree, and there will be sir the ratio of the vessel wall to the internal diameter is more, and the systemic vascular resistance is increased, sir.
So all these things occurs because of there is a deviation in the normal renin aldosterone pathway.
Yes.
Okay. So can you classify the systemic blood pressure, like what are the current guidelines? What is stage 1, stage 2, and those things?
Sir, sir, less than 120 mm of Hg systolic and less than 80 mm of Hg diastolic pressure is taken as normal, and sir, in the pre-hypertensive is 120 to 139 systolic blood pressure, and diastolic blood pressure 80 to 89 mm of Hg is taken as a pre-hypertensive, and sir, is in stage 1 stage 1 hypertension, sir, it is the systolic blood pressure will be 140 to 159, and the diastolic will be 80 to 90 to 90 to 100 mm of Hg, and in stage 2 it is sir more than 160 mm of Hg, and the diastolic will be more than 100 mm of Hg.
And what is a refractory and what is a resistant hypertension?
Sir,
What is resistant hypertension and what is refractory hypertension?
sir, in resistant hypertension, sir, that is not that cannot be, sir. That is not responsive to the treatment, sir. And in refractory hypertension, sir, it will, sir, after the treatment it will go away, but so as soon as treatment is stopped, sir, it will the blood pressure will increase.
Is there anything with the number of antihypertensive taking the person is taking? So resistance is basically a resistant hypertension is a resistant, but the hypertension episodes are not controlled even after taking 3 antihypertensive drugs. One of them should be diuretics. So similarly, the refractory is a one where more than 5 antihypertensive drugs required are there. Okay. So and what is what is the significance of a systolic hypertension or diastolic hypertension? What does it signify?
Sir, in the systolic hypertension is during the contraction phase of the heart. This is due to the preload of heart, and the diastolic will be because of the systemic vascular resistance during the diastolic phase.
So pathophysiologically, the diastolic blood pressure represents a microvascular level pathology, whereas the systolic says it is a macrovascular level pathology. And is there any special significance of both these? If the person is systolic hypertension, what can you predict for anesthesia? And if that is diastolic hypertension, can you what is the prediction for the anesthesia related complication?
Sir, because of hypertension, sir, there can be end organ damage, and sir, in cardiovascular there can be, sir, left ventricular hypertrophy, and because of that there is a more work during the diastolic phase. The atrium will be doing the more work to fill the left ventricle, and during, sir, tachycardia there will be more oxygen demand and chances of ischemia in the left ventricle, ischemia because of left ventricular hypertrophy. And
so if you which one is much more dangerous for perioperative morbidities, a systolic or a diastolic hypertension? Both are is different, but which one is much more concern for you?
Sir, diastolic, sir.
So it has been found that the person with diastolic hypertension has the increased risk of morbidity, especially cardiovascular accidents in the perioperative period. Okay, as you rightly told, it's much more a organ damage, end organ damage, suggestive end organ damage. So what are the end organ damage with a hypertension that occurs? What are the organs that are affected mostly, and how can you evaluate them?
Sir, mostly, sir, cerebral, and because of that there can be, sir, ischemic events, and there can be retinopathy, or there can be, sir, renal damage, and because of, sir, raised hypertension.
So it's the cardiovascular, CNS, and the renal are the mostly important affected. Okay. So in these patients, so if you start an antihypertensive, what is your target? What is the target of achievement? You said this patient is controlled on medications. So when do you say that your target is achieved and the patient blood pressure is controlled?
Sir, the target blood pressure will be, sir, less than 140 systolic and less than 90 diastolic blood pressure. Sir,
is there some different target pressure for diabetic and CKD patients?
Sir,
is the blood pressure target different for diabetic and chronic renal disease patients?
Sir, in chronic renal disease patients, it can be, sir, systolic will be, sir, less than 160, and diastolic will be, sir, less than 100, sir, mmHg.
No, and what about diabetics? you target for a lower rather than higher one. Okay, if it is 140, normal it is 130 by 80 target that you go for. So this patient, what are the investigation you ask for before the modified radical mastectomy?
Before this, I will advise for complete blood cell count hemogram to see the hemoglobin and the various cell count, WBC and platelet count, and I'll advise for a liver function test with liver enzyme, and renal function test and serum electrolytes, and ECG to see for any left ventricular hypertrophy or strain patterns, and chest X-ray for any lung pathology, or see the cardiothoracic ratios if there is a cardiomegaly in this patient.
Would you ask for any echocardiography in this patient?
If ECG, if there is any ECG finding and any kind of end organ damage is seen, sir, then I'll ask for echocardiography in this patient, sir. Since in patient for modified medical mastectomy that have undergone the chemotherapy, the echocardiography will be essential to see the ejection fraction of heart and wall movement.
All type of chemotherapy or any specific groups of drugs that the patient has received?
Sir, mostly cyclophosphamide and doxorubicin that are cardiotoxic. Echocardiography is essential.
So, these patients, why do you specifically ask for electrolytes in this patient?
Sir, because my patient is on hydrochlorothiazide, that is diuretic, sir. There can be electrolyte abnormality in these patients, sir. Mostly hypokalemia.
Any other what is the patient is on diuretics? What are the electrolyte abnormality that is you suspect?
Sir,
along with hypokalemia, what can occur?
Hyponatremia and hypokalemia and hypomagnesemia.
Yes, hypomagnesemia is important. Okay. And anything else?
Calcium, sir.
What will happen to calcium? There may be hypercalcemia, like we just. So that's okay. Mostly we go for a hypokalemia and hypomagnesemia. Okay. So this patient is receiving a diuretic and a AC inhibitor.
AC inhibitor.
So what are the concerns with AC inhibitors use?
Sir,
what are the concerns? What are the perioperative concerns with the patient is using AC inhibitors?
Sir, because of ACE inhibitors, there can be perioperative hypotension. Perioperative hypotension because of ACE inhibitor if there is a major fluid shift or prolonged fasting is there.
No, what sir, you are continuing the ACE inhibitors or you are stopping the what will happen if you stop the ACE inhibitors, and what will happen if you continue with the ACE inhibitors, and what are the current recommendations?
Sir, mostly, sir, in literature it is given that, sir, we can continue the ACE inhibitor in the surgery in which major fluid shift or hemodynamic variability is not predicted.
So what are the concerns? If you continue, what happens?
If you say it should be it should not be taken 10 hours prior to the surgery, and it is associated with the hypotension, which is not reactive to drugs.
So hypertension after induction. So if you continue ACE inhibitors, there is a chance that there is a hypertension which will be refractory to normal standard medications after induction. Okay. So what is in those cases? Is there any specific group of drug which are indicated? If the patient has a hypertension after induction after ACE inhibitors?
After induction, sir, we can use phenylephrine in 25 to 50 mics bolus, sir, and
Yes,
Sir,
that is okay. So if you stop it, what will happen? If you stop the ACE inhibitors, what will happen?
sir, we stop ACE inhibitors, and there can be, sir, raised, sir, raised sir, blood pressure, sir.
So there will be roller coaster ride. There will be much more fluctuation throughout the
Fluctuations and
So
volatility.
what is the current recommendations? Should you continue or should you stop?
Sir, I will avoid the ACE inhibitor prior to the, sir, prior to the surgery. 1 day prior to the surgery, and I will take my patient on, sir, calcium channel blocker for maintenance of blood pressure, and I will ask for blood pressure charting of the patient.
Okay, so if you want to stop the ACE inhibitors, does it depends on which type of ACE inhibitors if the patient is taking? Does it affect your decision making if it is a shorter acting ACE inhibitors or a longer acting ACE inhibitors, or if the patient is taking multiple antihypertensive along with the ACE inhibitors, or only single medication that is ACE inhibitors? Does your decision change?
Sir, for long-acting ACE inhibitors, sir, for long-acting ACE inhibitor, we can, sir, continue, and so for short-acting, sir, we have to stop prior to the surgery.
Is it not the reverse one? Because long-acting are much more prone to produce the post-induction hypertension. No? So what would normally, if the patient is taking a multiple antihypertensive drugs, and you can definitely stop the ACE inhibitors because already the patient is on 4 or 5 drugs. And if the patient is taking only one antihypertensive drugs, you can consider continuing it if it's not a major surgery, as you said. If there is no chance of major fluid shift and those things, you can definitely continue with that. Again, those drugs who can affect whether it's an pill or a after pill, because one is a longer acting, one is shorter acting. That can also, the shorter acting produces lesser chance of post-operative hypertension, post-induction hypertension. Okay. So, any other investigation you like in this patient? Am I audible, Dr. Raka?
No, sir. No, sir.
Okay. So you have done the investigations, and in this case, what will be the pre-operative?
I'll ask.
Yes.
So I will ask for, sir, consent, written and informed consent, and ask the, sir, NPO for 6 hours for solid food, and the blood demand to be sent, and sir, BP charting, and sir, I will ask to stop the ACE inhibitor and continue, sir, hydrochlorothiazide, and for the BP charting, and I will advise the pre-medication tablet ranitidine 150 mg OD, and tablet alprazolam 0.25 mg night before the surgery, and 2 hours prior to the surgery.
Okay. So if the patient, you go for the pre-anesthetic checkup, and the patient is having blood pressure of 230 over 110. So will you continue with the surgery, or you are planning to postpone the surgery?
Sir, I will take the patient, and sir, I will take another reading, see if the patient is, sir, anxious, and sir, if the BP drops to less than, sir, 180, 100, sir, I will take the case.
So your target most of the time for elective surgery, you take up any case that is less than systolic less than 180 and diastolic less than 100. Okay. Anything else you check during these things? Does cuff size or how you are measuring the blood pressure affect?
Yes, sir. For measurements, the sphygmomanometer should be adequately well calibrated, And sir, the size of a bladder should be 80% of the arm circumference, and sir, width should be 40% of the arm circumference.
So what will happen if it is smaller, and what will happen if you are using a larger curve?
If it is sir, smaller, sir, it will the readings, the measurement will be raised, and sir, if it is larger, the measurement will be sir
Yes.
decreased.
Do you have any guess how many percentage it will change with the not inadequate pressure? If you are using a larger cuff or a smaller cuff, what will be the approximate change in the blood pressure? Just any guess? So if you are using a smaller cuff, it's normally it will be give a higher reading, may drop to 20 to 30 milligram of mmHg. Okay. So with that, so if the person is, suppose the person is having you've taken multiple readings and all the readings are more than 200 or around 200 and diastolic is more than 110. So what will you do?
Sir, I'll see if the sir, because sir, this is in this case of in modified radical mastectomy, sir, this is a semi-emergency procedure, and sir, for that I will sir continue with the case, because sir, the risk benefit ratio is sir for the surgery to be done, sir.
And so you are thinking, because this is it is a cancer surgery will continue, but what do you define a hypertensive emergency and what is a hypertensive urgency?
Sir, hypertensive urgency, sir, there is a raised blood pressure more than systolic more than 180 and diastolic more than 100 mmHg. And if it is associated with any end organ damage, then sir, it is a hypertensive emergency.
And urgency?
Sir, urgency is raised blood pressure without any end organ damage. And sir, if the end organ damage is associated, then it is a hypertensive emergency.
So what do you category, if this person have a BP of 230 by 110, is it urgency or emergency?
Sir, I'll see for the sir, any end organ damage associated, like sir, there is a decrease urine output, or on fundoscopy there is a papillary edema, and sir, then it will
so
be
this person
emergency.
doesn't have anything, those things. The creat is not raised and those things are not there. So so this person is mostly a hypertensive urgency in that scenario.
Yes. Yes.
So in a hypertensive urgency, how do you treat this?
This is a hypertensive emergency, sir. I will give sir patient 5 to 20 mg of sir labetalol, and 5 to 20 mg of sir
even if
IV bolus with monitoring.
So if this is a purely elective, suppose laparoscopic cholecystectomy and with this BP, what will you do?
Sir, if it is a elective, purely elective procedure, sir, then I will delay the surgery and sir advise the patient for the adequate management of the blood pressure, and sir, after that I will tell the patient.
What is the time limit normally you give to the patient after which time the elective surgery should be done or controlled with a controlled blood pressure?
Sir, around 2 weeks, sir.
Say elective surgery, you can go for 4 to 6 weeks before reposting the surgery. And in a hypertensive emergency, that should be, like you told, if the patient is a hypertensive emergency, that should be managed immediately with intravenous antihypertensive before shifting or discharging the patient home for adequate management. You should, if it is an emergency, you should have to manage the patient immediately in a quiet room, and then you decide how to proceed. Okay. So in this patient, everything is okay. So you plan for this, and you plan to go ahead with the surgery. Okay. So if in this case also, if there is if you every time the BP recording is normal, but you go to see the patient is having a higher systolic blood pressure, what does it signify?
Sir, it is maybe because of the white coat hypertension. So because of anxiety
or anxiety. So most of the time that will only affect the systolic hypertension rather than a diastolic one. Okay. So with that, so any special thing you find in case of if the person is hypertensive on physical examination, any signs of hypertension that you can find if the person is a long-standing hypertensive? Different system, mainly in the cardiovascular system.
Sir, there can be, sir, edema associated, sir.
So if the person is failure, you will can find
failure, signs of failures.
Congestive heart failure. Anything else? Normally, if the person is not in failure, what is the most cardiovascular finding you find? Most common cardiovascular finding?
Sir, exercise tolerance will be less, sir. I'll ask for, sir.
Okay, and there will be left ventricular hypertrophy.
Edema. So there will be edema, sir. Periorbital and pedal edema will be there, sir.
Pedal edema will occur if the person is in congestive heart failure or the renal as involved.
Renal pathology, sir, is mostly associated.
Okay, so and this person is not on beta blocker. So what is the current recommendation regarding starting or continuing beta blocker in the perioperative period in a hypertensive patient?
So if the patient is on beta blocker for a long time, sir, it is beneficial. And sir, if the patient is taken on beta blocker in the pre-operative period, sir, sir, it is not advised to start the patient on beta blocker pre-operatively, sir. And sir, beta blocker, sir, is contraindicated for use in the patient with a reactive airway. And it can also mask the signs of, sir, hypertension and tachycardia related to the blood loss intraoperatively.
And do you recommend starting beta blocker? So if the patient is continuing on beta blocker, you continue that, and you don't start any beta blocker if the patient is non beta blocker.
And so beta blocker has shown, sir, some protective action in the cases of ischemic heart disease. But the patient, it decreases the heart rate and avoid the ischemic events.
So with that, so that this patient is, you plan for what is your plan for to go ahead with this surgery in this patient?
This, sir, I will take the patient inside the OT, sir, and attach all the ASM monitoring.
That's okay. So your plan, what is your plan? Say, general anesthesia, regional anesthesia.
I'll take this patient, sir, under general anesthesia and general anesthesia.
With tracheal intubation, or you go for TAVR?
So I'll go for tracheal intubation because, sir, in such surgery there can be, sir, positioning for the patient. In that, sir, airway has to be maintained. So
suppose in any case with the hypertensive patient, you can, is there a benefit of using a supraglottic airway device?
Yes, sir. Sir, there is a benefit of using supraglottic airway, sir. It avoids the laryngoscopic response during the intubation, and during the phase of immersion, during the phase of, sir, extubation, sir, it also reduces the coughing due to the coughing or reflex due to the endotracheal tube during the extubation phase.
Okay. What are the monitoring you will use in this patient?
Sir, in this patient, I will use, sir, on standard ASM monitor, sir, including, sir, ECG, sir, 5-lead ECG, and SpO2, and non-invasive blood pressure, and temperature, temperature, and to maintain the, sir, intra-op, to avoid intra-op hypothermia, and, sir, urine output should also be measured. For that, I will catheterize the patient.
Okay. So normally it depends upon catheterization is a small duration you can avoid, but you can definitely look after the urine output in this case. Okay, any major surgeries. So with this monitoring, how will you induce this patient?
I will Sir, I will induce this, sir. I will, sir, secure a widebore cannula in the, sir, ipsilateral arm, avoiding the side of the surgery. And sir, I will preload the patient prior to the induction. And sir, for anxiolysis, I will give a sir injection midazolam 1 mg, and so before that I will pre-oxygenate the patient, and I'll give sir injection midas 1 mg for anxiolysis, and injection fentanyl with 2 mics per kg body weight for reducing the laryngoscopic response, and decreasing the dose of induction agent intraoperatively. And I will induce this patient with injection etomitate, which is a cardiostable induction agent. And I'll, prior to the intubation, 90 seconds prior, I will give sir injection injection lignocaine 1.5 mg per kg to avoid the laryngoscopic response hemodynamic variability. And will intubate the patient with PVC endotracheal tube. And sir,
So you have used the xylocaine to reduce the response to endotracheal intubation and laryngoscopy and endotracheal intubation. So what are the different way of decreasing the endotracheal laryngoscopy and endotracheal intubation response? What are the different drugs or different things that you can do to decrease the response?
Decrease the laryngoscopic response. Sir, the laryngoscopy should be less than 15 seconds, and the plane of anesthesia should be deep. And sir, opioids can be used, like fentanyl can be used for 1 to 3 mics per kg body weight in higher doses. Or sir, in beta blockers like esmolol can be used at a dose of 0.5 to 1.5 mg per kg, 30 or 3 minutes prior to the laryngoscopy. And sir, other xylocaine also can be used. And xylocaine spray can also be used. And sir, other agents like nitroglycerin and calcium channel blockers can also be used.
So if you are using opioid, what should be the dose of opioid to decrease the laryngoscopic response? Or
So to decrease the sir, it should be sir 3 to 5 mics per kg body weight.
Yes. So normally what you are using is not going to be adequate dose. If you are using it to decrease laryngoscopy response, you have to use more than 3 mics, at least 3 to 5 mics or even more. Okay. And do you use etomitate standardly for all these patients?
Yes, sir. We can also use thiopentone and sir propofol in titrated doses.
Yes. So normally you don't use etomitate in these patients if the patient is not a CAD and other cardiac arteries. So you can go ahead with the normal standard induction agents like thiopentone and propofol. But as you correctly said, those should be titrated at small boluses rather than giving a instant bolus. Okay. So with that, you intubate the thing. So for maintenance, you have any preference? Any preference of inhalation agent?
For maintenance, I will use inhalational agents, sevoflurane and nitrous oxide. Sir, I would avoid the desflurane because the rapid change in the concentration of desflurane is associated with the tachycardia and raised blood pressure intraoperatively.
So any other drugs you will avoid during the intraoperative period or induction or maintenance?
Sir, intraoperatively, I will avoid sir NSAID for analgesia. Sir, that is associated with increasing sir blood pressure because of sir retention of sodium and sodium in the body.
Any other drug? In induction agent, any other specific?
Sir, ketamine, I would like to avoid, sir, because it is associated with increasing intracranial and blood pressure and all other pressure.
And regarding NSAIDs also, it is not a contraindication to use if the renal function is normal. You can definitely use it, but these are the concerns you should know. These are the concerns. Okay. So with that, you have we are maintaining any what about fluid? How do you maintain fluid?
Sir, I'll give the fluid according to the sir. There's a patient was on MPO since 6 hours, and sir, I'll calculate the maintenance fluid and promptly replace the blood loss because in patient in such in patient with hypertension, sir, these changes will not be evidently visible because of the rigid intravascular vasculature. So it will not be visible. So I will promptly replace the blood losses.
So if you, what are the concern? If you give lesser fluid, what will happen? And if you give higher fluid, what will happen?
So if I give sir lesser fluid, sir, there can be sir hypotension will be there, sir. And
so if adequate fluid is not replaced, lesser fluid are giving, that intraoperative hypertension and fluctuations will be much more. And
yes,
similarly, if you are giving a higher fluid than the required, usse kya hoga?
Sir, there will be sir increased preload on heart, and sir, there can be chances of ischemia.
Also, the chances of post-operative hypertension will be higher because the vasodilatory effect during the intraoperative will be gone, and the post-operative, the chance of post-operative hypertension will be high. Okay, so this patient after induction, suppose the BP crashed to 60/30, what will do?
BP is
during the intraoperative period, the BP just after induction, the BP crash, what will do?
Sir, I will first I will decrease the concentration of inhalational agent, not much, so that the awareness will be there. And after that, sir, I will increase the IV fluid and see for the fluid responsiveness. And if it still continue to decrease, I will give IV phenylephrine with the dose of 25 to 50 microliters.
Okay, so you will mostly decrease those things, give fluid, and what happens if during the surgery the patient BP goes to again 220/110 intraoperatively at a point? How will you manage?
Sir, I'll first of all, sir, I will rule out the factors like, sir, I will see for if the BP cuff is adequately, or sir.
Okay, everything is okay. You have checked those things. How will you manage?
Sir, I will see for the plane of anesthesia and pain or any kind of surgical stimulation is there, sir, and I'll see for if the bladder is full, sir, it can also cause several.
Now, how will you manage?
Sir, I'll manage it by, sir, giving, sir, giving the patient, sir, infusion for, sir, nitroglycerin. Nitroglycerin, sir, at
is anything else before that? Anything else you can do, or normally we do?
Sir, I'll see, give, sir, opioid for analgesia, sir, and increase the plane of anesthesia.
Is the VP is already 230.
Deepen the plane of anesthesia.
So if the analgesia is the part, will take some time. Anything else you can do before that?
So deepen the plane of anesthesia.
Yes, how will do that?
By increasing the concentration of inhaled anesthetic.
Yes, so those are the things mostly do fast, and you definitely take care of the analgesia and those things. Okay, so in this patient, so what is your plan for analgesia in this patient?
Sir, for this, I will, sir, use multimodal anesthesia, sir, in which I'll give, sir, IV PCM and opioids, and sir, after, sir, post-operatively, sir, I'll plan for, sir, paravertebral block in the fourth and fifth thoracic vertebrae, sir.
We'll put the block in preoperative period or after the surgery?
I'll put the block after the surgery, sir, under the GA.
Why don't you put the block before the surgery and take advantage of that during intraoperative period?
Sir, I can also, sir, do that.
Do you? So, what are the other options for regional anesthesia for breast surgery?
Sir, we can also do it in, sir. So we can also do, sir, awake by, sir, giving, sir, thoracic epidural to the patient, and, sir, and continuous care, putting the catheter in the paravertebral space. So by that also can be, sir, it can be done. And post-operatively, sir, for analgesia, we can give PEC1, PEC2 block and serratus anterior block.
So, can you say what are the nerve supply of the breast?
The breast is supplied with a, sir, second to sixth anterior and lateral intercostal nerves, which originate from the, sir, spinal cord at the level of thoracic vertebrae, and it is in close proximity with the serratus anterior and going under the, sir, rib of the same.
So you see, you can do it without general anesthesia also, and you can supplement the regional anesthesia with general anesthesia for pain, intra and post management. So, is there any advantage of using these regional blocks in the hypertensive patients?
Sir, using this regional block in hypertensive patients, sir, can help in decreasing the pain intraoperatively and postoperatively. So that can be a cause of raised blood pressure during these periods. And sir, it also reduces the opioid dose that is post-operative to the respiratory depression and decreased bowel movement and post-operative nausea vomiting.
Okay, so between paravertebral and epidural, which one do you prefer and why?
In epidural, sir, there will be, sir, bilateral blockade will be there, and in, sir, paravertebral there is a unilateral blockade on the side we are giving. And
any other benefit, any other advantage of using a paravertebral?
in paravertebral, sir, there is a decreased sympathetic blockade, sir. Paravertebral.
Also, you are moving away from the neuraxial, no? A bit. So the chances
Yes,
of
chance.
any neuraxial complications will be less.
Yes.
That is the main advantage. No? So if you are planning a paravertebral block, at which level you block, and if you are not using a catheter, what is the volume you should use?
Sir, we should use around 15 ml of, sir, long-acting, sir, local anesthetic like, sir.
And which level you will give?
Sir, we'll give it at level, sir, T for T3 and T4, and, sir, for axillary blockade we'll give it at T2.
Okay, so 15 level is less. You have at least go for 20 ml or more. Okay. So how is PEC1, PEC2 is given, and how is serratus plane block is given?
Sir,
At what level?
Sir, for PEC1, PEC2 block, sir, it is given at, sir, below the clavicular, sir, it will given at the third rib, and in plane by using, sir, ultrasound guided in plane, and sir, first there will be pectoralis major, and under this, sir, pectoralis minor, the PEC1 block will be given, and after that, sir, serratus anterior will be there for PEC2 block.
At which level? The serratus block is given at which level?
Serratus is given at, sir, fourth rib, sir.
Okay. So do you use ultrasound?
Sir, we can use ultrasound, and or we can, sir, ask the surgeon to, sir.
So using ultrasound is a better model of giving this. Okay, so with this here in this patient, so what have you used in this patient? What you are going to use in regional anesthesia, or you are only systemic anesthesia? Systemic anesthesia.
Sir, I will give sir. Sir, after induction, we can we can give sir a paravertebral block to this patient, and after that we'll start the surgery. Sir, it will give around 10 to 12 hours of sir analgesia to the patient. Sir.
Okay, so so the surgery goes on smoothly. So now, do you take any special precautions during extubation in this patient?
Extubation, sir.
Yes,
Extubation, sir.
extubation.
And during extubation, sir, I will, sir, I'll extubate this patient in a deeper plane to avoid the sympathetic response because of the cuffing with the endotracheal tube in situ, sir, and that will raise the tachycardia. And,
how do you want to use a deeper plane extubation, and what is a deeper plane extubation? Why can't you use other methods to decrease the extubation response?
Sir,
you practice other extubation normally in this patient?
Sir, we'll prefer the extubation deeper plane, sir, to avoid sir the tachycardia and raised blood pressure, sir, in this patient.
So
and sir, we can also use sir beta blocker like esmolol to decrease the response, and interoperative opioids are if given in the liberal doses, this can be avoided, sir.
So what is the disadvantage of using a deeper plane extubation rather than in the pharmacological treatment?
Sir, in patients, sir, in patient with difficult airway or obese patients, sir, there can be chances of sir we can lose the airway.
Post extubation airway complications, airway related complications or problem will be high, na? So you go for a better the same things that you used for prevent response or laryngoscopy and intubation can be used at this point also. You have to be same reason. Okay. So as you said, you can use a beta blocker and those things.
Vasodilator like nitroglycerin.
So if the patient again in the postoperative period, the patient is in the recovery, and the patient again having a BP of around 210 by 110. So what are the causes that may cause this postoperative hypertension?
Sir, during the postoperative period, sir, it can be because of sir inadequate analgesia, or sir patient can be hypothermic or hypercarbia will be there. And
anything else?
So because of sir increased intraoperative fluid is being given,
yes.
sir. Yes. And
so
sir,
the reason may be analgesia lack, mainly most commonly it's an analgesia problem, or other causes like increased intraoperative fluids, full bladder, or
sir, hypercarbia, hypothermia, and hypoxia.
Hypothermia, those things. So how will you manage this?
Sir, will give the patient sir opioid analgesia, or sir will eliminate these factors after that, sir.
So you will treat whatever the cause is.
Cause is, sir.
Okay. So if it is a full bladder, you catheterize. If there is pain, you give analgesia. Even if all those things, if the patient persistent having a hypertension, then what will you do?
Even after that, if the patient is hypertensive, sir, I will take the patient on IV. Sir, continue the medication, sir, which was being given to the patient.
You can restart those medications.
Restart the antihypertensive.
But if it will take some time. If it is again an emergency, what will you give? What are the IV agent that will? You
Sir,
choose
I'll use sir labetalol, sir.
any preference why you choose a labetalol rather than a calcium channel blocker?
Sir, labetalol, sir, calcium channel blocker can also be used, sir, like sir, newer.
So what is the disadvantage of using labetalol?
Sir, there can be, sir, it is a, sir, there is a beta blocker action that can cause in reactive airway. There can be, sir,
Okay,
airway
one thing is
difficulty
that. Anything
and,
else?
sir, bradycardia.
Yes.
Bradycardia.
So beta blocker, if the patient is already having a lesser heart rate or heart rate, if the patient is previously beta blocker, it's a long-acting agent. Labetalol is a long-acting agent. So
Yes, sir.
repeated uses may be a concern. So rather than calcium channel blockers may be a better agent. Can you use nitroprusside in this case?
Yeah.
Can you use NTG or sodium nitroprusside for postoperative management?
Yes, sir, we can use nitroglycerin, but it is associated with a tachycardia, which we want to avoid, sir, so that
So
I'll
what
not
is the
prefer.
mechanism of action of nitroglycerin and sodium nitroprusside?
Sir, they act by atrio and venodilatation by secreting the nitrous oxide vascular nitric oxide in the vasculature, and it will dilate atrial and venous vasculature. So, sir, there is a there will be hypotension and a reflex tachycardia will be there.
And any other concern with use of nitroprusside if you are using nitroprusside at any time?
Sir, nitroprusside is associated with cyanide toxicity if it is used, and methylglobinemia will be there.
Okay. So
Cyanide
you
toxicity.
use mostly NTG and those things as a bridging therapy till other effects.
Yes, sir. And sir, nitroprusside we also have to cover it and protect it from sunlight. So
do we have to cover it? Do you routinely cover those things?
sir, we have to cover the syringe in which nitroprusside is being made, and sir, to avoid the exposure to sunlight. So it will, sir, the drug will, sir, decompose.
So as you told, is there any sunlight in the OT?
No, sir, light, not sunlight, exposure from the light source. So
definitely those are the concerns and older concerns. Nowadays, mostly how much it is normally, it is affected around 8%. The degradation is around 8%. So you can increase the dose and titrate. You are using this short duration of time. So what you are telling is correct, but you should know what is the effect. So you have managed the post-operative period, and if you are using a catheter or for regional anesthesia, so how much duration and how will you manage that for post-operative anesthesia? You are using a paravertebral catheter.
Sir, with epidural catheter, sir, after this, sir, bolus of 5 ml of long-acting sir, local anesthetic, we can start the patient on, sir, 3 to 5 ml of 5 ml per hour of infusion of 0.25% of bupivacaine.
Okay, and preferably use a multimodal approach also.
Yes.
Okay, so we have discussed many aspects of the patient, hypertensive patient who is posted for a surgical assistant of modified radical mastectomy. Some person will be maybe missed. So I will now request Dr. Priya to continue with a summary of the lecture or the recommendation that we have currently in literature for managing a hypertensive patient for elective surgery. Dr. Priya, please.
Thank you so much, Dr. Vikas. It was a very extensive and very elaborate case discussion. I'm sure that students must have benefited from this case discussion. Video. Okay. So I'll just quickly summarize with the this case, perioperative management of patient with systemic hypertension. So how to define systemic hypertension? It is of two types, primary and secondary. So primary systemic hypertension is defined as persistent, that is average of 2 or more readings on 2 or more occasions. The persistent systolic blood pressure more than 140 mmHg and or diastolic blood pressure more than 90 mmHg in adults in absence of any known precipitating causes, primary systemic hypertension. So JNC 8, that is Joint National Committee 8, they have categorized the hypertension as previously assumed, as previously believed, 120/80 was optimal BP, but now the normal BP is classified as less than 120/80, and they have added this category pre-hypertension or elevated hypertension, that is between 120 and 139 systolic and 80 to 89 diastolic BP. Then comes the stage 1 hypertension, that is 140 to 159 systolic and 90 to 99 diastolic. And beyond 160 mmHg systolic and diastolic more than 100 mmHg is stage 2 hypertension. European Society of Hypertension 2018, they categorize blood pressure as optimal, that is less than 120/80, normal 120 to 129 systolic and 80 to 84 diastolic. They have divided the pre-hypertension into normal and high normal. High normal comes under 130 to 139 systolic and 85 to 89 diastolic. Then they have graded 1, 2, 3 hypertension. 1 is 140 to 159 systolic, 90 to 99 diastolic, and grade 2 is 160 to 179 systolic and 100 to 109 diastolic. Grade 3 is more than 80 and 110 mmHg. Isolated systolic hypertension is when systolic BP is more than 140, but diastolic remains less than 90 mmHg. So we can classify hypertension as essential, that is primary or with unknown etiology. And if there is some underlying secondary cause because of renal, endocrine, neurogenic, or any miscellaneous causes, we call it secondary hypertension. So renal causes are manifold, like acute chronic glomerulonephritis, chronic pyelonephritis, polycystic kidney, diabetic nephropathy. In endocrine, there are so many conditions in which BP can be raised, like adrenal causes, Cushing's, primary aldosteronism, congenital adrenal hyperplasia, pheochromocytoma, neurogenic increased intracranial tension, and dysautonomia, sleep apnea. In miscellaneous, coarctation of aorta, PIH, polyarthritis nodosa. So when we see the basis and on a lifetime basis, it consists of a very delicate balance between nervous system, hormonal system to maintain the blood pressure to normal or near normal. Basic mechanism is the feedback control mechanism that consists of pressure sensors and effector mechanism. Basically, the two type of mechanism are there. First is fast and neurally mediated baroreceptor mechanism, and a slower or for long-term control of blood pressure, that is hormonally regulated RAS, that is renin angiotensin aldosterone mechanism. The sympathetic vasoconstrictor system is very important in maintaining the BP regulation, which is located in reticular system and lower third of pons, and is responsible for providing sympathetic and parasympathetic outflow to the effector organs. So when we see the baroreceptor, mechanism, it is initiated by the spherocytosis that is situated in the receptors within aortic arch and carotid bodies that transmit the feedback signals to central nervous system for minute-to-minute regulation. This respond very rapidly. So these signals are nucleus tractus solitarius in the medulla, and they inhibit the vasoconstrictor activity center and stimulate the vagal center. So basically, these four centers, that is arterioles, post-capillary venules, heart, and fourth one is kidney. These centers are mainly involved in maintaining minute-to-minute BP regulation. Baroreflex, humoral mechanism, renin-angiotensin, aldosterone system, they regulate all these above 4 sites. Also, the local agent like nitric oxide, they also help in regulating the blood pressure. Blood pressure, that is basically cardiac output and the systemic vascular resistance. So they maintain this. In hypertensive patient, this baroreflex and renal blood volume control system, it is set at higher level. So auto-regulation also needs to be, we have to be cautious when we are lowering the blood pressure, because the cerebral auto-regulation, they all are set to, they shift towards the right side and set at a higher level. And all antihypertensive acts via interfering with the normal mechanism. So this is the algorithm that shows the renin-angiotensin-aldosterone system, which is, as I said, it is slow hormonal mechanism for long-term blood pressure control. So it starts with angiotensinogen. So renin cleaves this angiotensinogen, renin that is secreted by juxtaglomerular cells of kidney, and angiotensinogen generated by liver. Renin cleaves the angiotensinogen into angiotensin 1. This angiotensin 1, angiotensin converting enzyme acts on this angiotensin 1 and converts it into angiotensin 2. Basically, this angiotensin 2 acts on various sites and it controls the blood pressure and it increases the blood pressure. So it helps in norepinephrine release. It acts on pituitary gland and release vasopressin. It acts on adrenal cortex and release aldosterone. That leads to sodium water reabsorption through kidneys. It acts on brain and increases the thirst. So basically, on all sides, it helps to increase the blood pressure. And various antihypertensive agents that act on this RAS mechanism, they act at different, that is shown in the red color, like renin inhibitors, they act on renin and inhibit the conversion of angiotensinogen to angiotensin 1. And AC inhibitors, they act at this site and they inhibit the conversion of angiotensin 1 to 2 and hence help in reducing the blood pressure. So this hypertension, this has effect on each and every organ of the body. So all the organ, if hypertension is persistent, it affects all the organ and causes end organ damage. In cardiovascular system, it causes left ventricular hypertrophy, angina, myocardial infarction. It can cause arrhythmias, CCF, and aortic dissection. In brain, it can lead to stroke, transient ischemic attack, hypertensive encephalopathy. It can lead to renal nephropathy and retinopathy and papilledema also. So when patient is in pre-hypertensive phase, he is usually asymptomatic, and then it affects each and every organ of the body. In initial phases, in kidney, it causes proteinuria, nephrosclerosis. That can lead to chronic kidney disease and end-stage renal disease. Heart, left ventricular hypertrophy, it can lead to coronary artery disease, angina, systolic diastolic dysfunction, various conduction abnormalities, and can lead to CCF, MI, and ventricular tachycardia and fibrillation. Similarly, in brain, it can lead to retinopathy, dementia, TIA, and stroke. So what should be our preoperative goals? It is different for elective procedures and it is different for emergency procedure. So it is always a dilemma for anesthetist when to cancel the case, when to proceed with the case if patient is hypertensive. So there are different guidelines for elective and emergency. So asymptomatic patient with mild to moderate, that is stage 1 and 2, we should proceed without increased risk. And evidence of end organ damage should be considered, like in severe hypertension. In those cases, stage 3 hypertension, BP should be gradually lowered to 140/90 over 6 to 8 weeks. There is no cosmetic correction. There is nothing like that, emergency correction of blood pressure and proceed with the case. But in case of emergency procedure, we have to take up the case. So maintain the systolic and diastolic BP in around 20% of baseline and mean arterial pressure in around 25% of baseline. So 25% decrease in mean arterial pressure usually reaches the lower limit of autoregulation. So this is the recommended blood pressure goals according to JNC 8. We will discuss that in general goal should be less than 140/90, but in older patient it is less than 150/90, but with diabetes and chronic kidney disease, again it is less than 140/90. So there is some difference in JNC 8 and recommendation of AHA. When there is initiation of treatment threshold and target, JNC 8 says in adults more than 60-year-old, systolic and diastolic treatment initiation threshold and target of 150/90, while AHA-ACC recommends lower the systolic treatment initiation threshold to 140 for adults less than 80-year-old. Similarly, there is some racial difference in non-Black adults, including diabetes. First-line therapy, according to JNC 8, includes thiazide, calcium channel blocker, AC inhibitors, and angiotensin receptor blockers. While in Black adults, including diabetes, first-line therapy include thiazide or calcium channel blocker. And with chronic kidney disease, first-line therapy include AC inhibitors and angiotensin receptor blocker. While in AHA, they recommend multi-drug therapy for Black adults. So angiotensin antihypertensive agent mainly targets this RAS, renin-angiotensin system. These come under the first-line treatment. AC inhibitors like captopril, lisinopril, ramipril, and angiotensin receptor blockers like all the sartans, losartan, valsartan, candesartan, and direct renin antagonists like elacestrant. Then alpha blockers are there, propranolol. These usually come under the later regime. This does not come under the first line treatment. So these are propranolol, metoprolol, atenolol, and combined alpha beta blockers like labetalol, carvedilol, and alpha blockers like prazosin, terazosin, and phentolamine. Calcium channel blockers, they come in the first line treatment of hypertension. They have classes phenylalkylamines like verapamil, dihydropyridine like amlodipine, and benzothiazepine diltiazem. Diuretics also come under first line treatment of hypertension, which are thiazides, hydrochlorothiazide, loop diuretics, that is furosemide, and potassium sparing or aldosterone antagonists like spironolactone. Other antihypertensive agents are vasodilator, hydralazine, minoxidil, and centrally acting alpha-2 agonist, clonidine, and methyl dopa, and ganglionic blockers like trimethoprim. So blood pressure is basically correlate with cardiac output and vascular resistance. Cardiac output is based on contractility, heart rate, and preload. And vascular resistance through arterial and venous vasodilation. So the centrally acting agent, they act on central nervous system, which again act on heart, and it decreases the contractility and heart rate. Beta blockers, they act on beta-2 receptors of heart and also on RAS system, and they act on both by reducing heart rate contractility as well as by arterial and venous vasodilation. Diuretics, they act on kidney by salt and water balance the effect, and they decreases the preload and hence decrease the cardiac output. AC inhibitors and renin antagonists, they act on RAS system and they decrease the preload and arterial and venous vasodilation. Calcium channel blocker, they act on heart as well as vascular smooth muscle and reduce the BP. These are the various antihypertensive agents, their dosage, onset, and duration. So these nitroprusside, nitroglycerin, esmolol, labetalol, we can use it as bridging therapy when we have stopped AC inhibitors or in the post-op period before resuming their usual antihypertensive agents. So these short-acting antihypertensives can be used as bridging therapy during perioperative period. So preoperative essence, if we see, we need to know that whether hypertension is primary or secondary. We should know about the cause, underlying cause of hypertension, and what is the stage of hypertension, whether a patient is taking treatment or not, whether it is white coat hypertension, anxiety related, and what organ damages have happened. So we need to have some investigations beforehand, and we should look for CVA, CAD, LVH, and creatinine report should we see, and X-ray in hypertensive breathless patients. So in evaluation, we do the systemic investigation that include the CBC, renal function test, electrolytes, liver function test, sugar levels, ECG, X-ray, and investigation to ascertain the underlying cause, ultrasound abdomen, renal function test, thyroid profile, fasting blood sugar, HbA1c, cortisol, vanillin mandelic acid, and to ascertain end organ damage, echo, chest X-ray, ECG, fundus examination, and pertaining to antihypertensive treatment, electrolytes, and echo as described by Dr. Vikash during the case discussion. So preoperatively, all antihypertensive drugs should be continued even on the day of surgery. And regarding AC inhibitors and ARBs, they may be omitted on the day of surgery if major hemodynamic changes or major fluid shifts are anticipated during the surgery. Otherwise, they can be continued. And hypokalemia, hypomagnesemia should be treated if present and if patient is on diuretics. And in case of white coat hypertension, benzodiazepine should be administered as pre-medication night before the surgery. So in pre-medication, anxiolysis is very important. Beta blocker, calcium channel blockers to continue. ARBs can be discontinued. Otherwise, it can cause refractory hypotension. So possibly 10 hours before it should be stopped. Clonidine for better hemodynamics and sedation. And Dexmed better in myocardial infarction. But increased incidence of hypotension and bradycardia should be kept in mind. So in intraoperatively, monitoring depends on individual cases. Basic monitoring is needed in all cases like ECG, NIPP, pulse oximetry, ETCO2, urine output. In cases where major fluid shift is anticipated or major cardiac case or other cardiac condition is involved, then we'll need the invasive BP monitoring, like pulmonary artery catheter only for patient with CCF or recent MI. So basic intraoperative goal is to minimize wide fluctuations of BP and to prevent myocardial ischemia, cerebral hypoperfusion, cerebral hemorrhage, and hypertensive encephalopathy and renal failure. As these patients are very prone to wide swing in blood pressure during induction, emergence, and even during the surgery because of surgical stimulus. So we have to avoid these wide fluctuations. And it can be disastrous. So this intraoperative hypotension and hypertension can be caused by various reasons, like the stimulus of laryngoscopy, intubation, surgical stimulus, inadequate plane of anesthesia or analgesia, hypothermia, hypervolemia, during reversal and recovery when patient is coming out, if hypoxia happens or full bladder, it all can cause to hypertension. While the sympathetic blockade by spinal epidural anesthesia or due to inhalational anesthetic blood loss, hypovolemia, mechanical ventilation, arrhythmia, other drugs, all can lead to hypotension. So while induction has to be very properly managed, the usual drugs inducing agents like thiopentone, propofol, and fentanyl are acceptable, but if given in titrated doses and very slow. We have to be very cautious about this as it can cause excessive hypotension. Etomidate is okay, but ketamine can raise heart rate and it can increase the BP. So ketamine is not advisable. And during laryngoscopy and intubation is a very strong stimulus. It can lead to very strong sympathetic stimulus. And because of that, wide fluctuations of BP can happen and it can increase the BP during the time of laryngoscopy. So the time of laryngoscopy should be minimized. Aim should be less than 15 seconds. Some drugs are there that we can use to blunt this laryngoscopy response, like opioids, lignocaine, esmolol, labetalol. And intraoperative hypertension can be controlled by either anesthetic or also by antihypertensive agents. So opioids, inhalational agent, butorphanol, lignocaine, and obviously the balanced anesthesia and is very important to control the hypertension. The antihypertensive agent that can be used are adrenergic blockers, alpha blockers, as we have already discussed, beta blockers, and combined alpha beta blockers like labetalol. Calcium channel blocker, diltiazem, nicardipine, verapamil can be used. AC inhibitors, enalapril can be used. Direct vasodilators, hydralazine, nitroglycerin, and nitroprusside can be used in IV infusion. And dopaminergic agonist, phenol-dopam can be used. We should be cautious about mean arterial pressure that should be maintained between 20% of baseline, because in these patients, the auto-regulation, it has shifted up. So we should not target BP to be very low. It should be around 20% of baseline. We should use regional anesthesia and analgesia wherever possible, because pain is one factor that can cause to increase in blood pressure intraoperatively as well as during emergence and post-operative period. We have to keep this in mind that IPPV and hypocapnia can decrease cardiac output. Intraoperatively, fluid management is very important, because the patient who are already on diuretic therapy and vasoconstrictor, they usually are hypovolemic. And adequate fluid replacement without overhydration is important to prevent post-op hypertension. In presence of left ventricular hypertrophy, left ventricular compliance curve shifts upwards and leftward. A higher left ventricular diastolic pressure is attained, thus higher pulmonary artery occlusion pressure is needed. So hypertension in post-operative period may also be result of intravascular volume overload from excessive intraoperative fluid therapy. It can persist up to 48 hours until the fluid has been mobilized from the extravascular space. It can also rise due to discontinuation of blood pressure medication post-operatively. So the bridging therapy is very important. That has to be kept in mind, that IV short-acting drugs can be used. During extubation and emergence, very important point are adequate analgesia should be maintained. Wherever possible, regional blocks can be used to supplement analgesia. Antihypertensive should be considered before extubation. Hypothermia, hypoxia, hypercarbia, full bladder, all these should be avoided. So these are the post-operative concerns that can lead to hypertension, as we have discussed. So there is always a dilemma in anesthetists, that when we should cancel the patient and when we should proceed with the cases. So this is just to summarize that in stage 1 and 2 hypertension, who do not have evidence of organ dysfunction, thus we should proceed to the surgery. Although surgery may not have to be delayed, but appropriate referral should be made so that patient will have future appropriate post-operative management of inadequately managed hypertension. We should watch out for intraoperative labile and fluctuation blood pressure, and significant target organ involvement should be considered for preoperative treatment. In case of stage 3 hypertension, it is probably justified to postpone elective surgery to investigate for target organ damage and to institute therapy. Stage 4 hypertension, it presents significant perioperative risk and surgery should be deferred for treatment. And there is no place for cosmetic correction immediately prior to surgery. And these patients should be given at least 4 to 6 weeks to optimize. Isolated systolic hypertension more than 180 and pulse pressure more than 80 is reasonable reason to postpone for optimization of BP. We should remember that hypertension has disappeared from clinical risk from perioperative guidelines, but hypertension still a concern for the perioperative period. It has to be managed properly. Left ventricular hypertrophy, tachycardia, and hypotension, they are the dreadful triad in hypertensive patient. So to conclude, basically we need to identify the cause of hypertension if present, end organ damage to be identified, and goal of controlling perioperative hypertension is to protect organ function. Proceed with elective surgery for class 1 and 2 and maintain BP to 20% of baseline. All antihypertensives should be continued till the day of the surgery. Intraoperatively, fluid management is very important and special care during induction and extubation. Thank you.
Thank you, Dr. Supriya, for an extensive guidelines and recommendations that we have currently for management of hypertension. Is there any questions?
No questions as such, sir. No questions in the chat box. I think we may conclude the session, sir.
Okay. Thank you, Dr. Akash, Dr. Supriya. Now we'll leave. We'll continue with the next program that we have.
Thank you, sir. Thank you for your such detailed discussion about hypertension. Thank you, Dr. Supriya, for such an informative presentation on hypertension and its implications for anesthesia. So we will now move on to our next session. Moving on to the next session, I would like to introduce the chairperson for this session, Dr. Vijay Kumar Nagpal. Sir is professor at ABBIMS and Dr. RML Hospital, New Delhi, and sir's area of keen interest are pediatric and cardiac anesthesia. We welcome you, sir, and over to you, sir, for the proceedings of this session.
Thank you, Dr. Nitin. We have today. We have teams today. Professor Mohandeep Kaur. She is the head of the department and professor and consultant at ABBIMS and Dr. RML Hospital. Her area of interests are critical care, trauma and resuscitation, airway management, ethics in anesthesia, research, medical education, and administratively, she is aware of good relations within the department and between departments.